The next is a case presentation of double ECMO by Dr. Madan. Dr. Madan is a consultant cardiac anesthetist at MGM Healthcare, Chennai.
Good afternoon to everybody. I should thank first Dr. Suresh Rao sir and Dr. KRB sir for giving this opportunity. Anyway, I think it's lunchtime. Most of them must be exhausted. I'll try to finish it as fast as possible. So we are doing a case report on double ECMO. For a single patient, we have initiated ECMO 2 times. And what is the reason for the second time initiation, whether it was a reversible cause or irreversible cause, that is what we are going to discuss in detail. So this is a patient named Deepak, 38 years male from Rajkot. So he had a flu-like symptoms on 3rd week of March, and is known case of diabetic and is known case of obesity. And he was being COVID positive on 25th of March and treated with standard COVID protocols in outside hospital, that is in Rajkot. And that day they have done a CT, where his CT severity score was around 6/25. On 30th, he had a clinical worsening with desaturation, and he was maintained with HFNC 60 liters with 80% FiO2. On next day, on 1st of April, patient has been intubated and COVID protocol ventilator strategies were being followed. Then after 7 days later, patient has been tracked and followed by bronchoscopy, and his condition deteriorated in spite of ventilator support with 100% FiO2. And the bystanders approached our MGM hospital, and they discussed with our team, which was led by Dr. KRB sir, and our team has planned to assess the patient in Rajkot. So we assessed the patient in Rajkot, and ECMO has been initiated by our team on 11/4/2021, and he was being airlifted from Rajkot to Chennai with ECMO support. So this is the airlifted image, and Dr. Murli was the person heading the team. So the patient, we received this patient on 12th of March, and we thoroughly investigated, and optimal medical management has been planned. Slowly we weaned the patient, gradual weaning we tried, and daily chair mobilization was done, and we done serial bronchoscopies, and thorough bronchoalveolar lavage was given, and the serum and BAL galactomin were positive, and in view of X-ray and CT images, it was showing some cavities, which was suggestive of fungal infection. So we started appropriate antifungal has been started, and this patient was being registered for bilateral lung transplant. So this is the bronchoscope of the patient. So his bronchus was a lot of secretion, and it was quite bad. So regular suctioning, everything has been done. And this is the X-ray at the time of receiving the patient. So X-ray was also quite bad. It was like bilateral patchy infiltrates were found all over. And on 28/4, we sent a blood culture where Enterococcus faecium was grown in the blood. And after 2 days later, we have done a CT chest where it was showing extensive diffuse ground glass opacities was present, and cavitating lesion was there in most of the segments of the lung. So this is the CT chest report of the patient. So we got ID consultation, and appropriate antibiotics and antifungal had been optimized. So in this patient, the BAL which we done on 19, 22nd and 24 was positive for Acinetobacter baumannii. And this patient was gradually weaned from ECMO according to our institution ECMO protocol. And on 28/4, this patient has been off ECMO, and we have decannulated the patient. Patient was stable, was on mechanical ventilator, and patient was mobilized to chair post-ECMO. And patient was put on CPAP as per our weaning protocols. On 5th, after 5 days later, patient developed a coffee ground aspirate was noted. So we suspected some DIC, and sepsis was suspected because of the deranged LFT. So we got a GI opinion, and we avoided all the hepatotoxic drugs, and antibiotic were being escalated. On 6th, we repeated a CT for this patient, and compared to the old CT, there was increased in cavities has been increased, and CT was looking progressively, it was becoming bad. On 7th, the patient developed breathing difficulty, and from CPAP, we have put the patient on full ventilation, SIME. On 9th, again, we sent a blood culture. It was second time, it was showing Enterococcus faecium in the blood. And same, again, we repeated a BAL, which was showing on 10th and 12th, same Pseudomonas aeruginosa has been grown. And 11th, this patient developed fever with severe breathing difficulty and abdominal distension. So 11th night, patient went on full ventilation. Despite maximum ventilatory support, his PCO2 continuously worsened, and made him severe acidotic. So we hand ventilated him nearly for 3 hours. We maintained to maintain saturation and to maintain immunological stability. All the antibiotics were escalated in view of new onset sepsis. Echo was being done emergently to rule out any pulmonary embolism, and we plan to reinitiate ECMO, and all the vessels has been assessed because we plan to reinitiate the ECMO in the same vessel, right IJV and the right femoral vein. Then on early morning 12th, we informed the bystanders and we got a high-risk consent. We reinitiated VV ECMO followed by bronchoscope, and we sent a BAL. Even that BAL was showing Acinetobacter baumannii. And that day after ECMO initiation, we shifted the patient with ECMO for CT chest, and the CT chest has been progressively worsened and consolidation has been increased. So this is the CT chest image. And his LFTs, his labs were looking quite bad, and cytosol filter was being initiated, and we did serial bronchoscopes, and patient, in spite of all those things, continued to have high grade of fever with hypotension. So we suspected some new onset sepsis. Serial X-rays have been done, and there are multiple cavities which has been in the serial chest X-rays, and we are treated with appropriate IV antifungals. So this is the LFTs. So LFTs was grossly deranged. So due to this grossly deranged, we connected the cytosol filter also. And this patient, we prone this patient. 6 cycles of proning was done, which lasts more than 12 hours. Usually our institution protocol is that we prone the patient more than 6 cycles, so which is more than 12 hours. And after proning, we noted some signs of improved oxygenation and tidal volume. So this is the proning image of the patient. So we proned him. We made sure all the pressure points has been protected, and with proper sedation and neuromuscular blocking drugs, we proned the patient. So patient gradually improved with adequate oxygenation, and his hemodynamics was stable, and ABG parameters were looking good. On 28th of May, we weaned the ECMO slowly according to our weaning protocols, and we removed the ECMO. Again on 28th, before weaning the patient, we sent the blood culture which was showing Enterococcus faecium, and we got ID consultation opinion, and appropriate antibiotic has been initiated. On next day, post ECMO removal, patient desaturated, and severe respiratory acidosis was been noted. So we did the check bronch, and we found the tracheostomy tube has been blocked. So we again changed the tube. Then finally we settled the patient. We chair mobilized. We changed all the lines. Then we started RT feeding, and rehabilitation was done for the patient. And we gave a comprehensive ICU protocol has been done. So we gradually weaned the patient. Night time we put the patient on CPAP, and morning time we used to put the patient on TP trial. And we weaned off ventilator and regular chair mobilization. Standing walking support has been given, and the physiotherapy, active physiotherapy was been given, and IV antivirus was started in view of raised CME levels, and in the discussion of ID team. And after 5 days later, BiPAP has been initiated. Patient clinically improved with adequate oral diet, and patient was out of bed mobilization. Then patient had one episode of fever. Again we repeated blood culture which was showing Enterococcus faecium. So again we started appropriate antibiotics, and low dose of inotropes has been initiated. So on 19/6, CT chest was done, where the ground glass opacities were better, and the CT chest was looking little better, and complete resolution was being found, and even the CT paranasal sinus was being normal. And this patient was thoroughly investigated on daily basis for blood counts, sepsis markers, coagulation profile, renal and liver parameters. Attenders were counseled in detail about clinical condition and the treatment plan of the patient. So this is the CT chest of the patient post removal of ECMO before shifting the patient to the ward. And even the X-ray lung also shows some sort of better improvement. Finally, patient has been shifted to ward with minimal oxygen support. Patient was stable in ward. We mobilized the patient with 0.5 liters of oxygen, nasal plungers, and sleep study was done. And patient was discharged on 10/7 with medication asked to review after 1 week. So the first VV ECMO initiated for this patient was on 11th, and we removed it on 28th, which was 18 days. And second VV ECMO we initiated on 12/5 and removed on 25, which was 9 days. And the second ECMO we initiated, it was a reversible cause, very likely sepsis or hospital acquired pneumonia. So the duration of his hospital stay was around 87 days, and patient was on regular follow-up. So the main scenario in this, the take-home message is that the obesity. So due to obesity, this patient was having persistent GB sludge. And due to this post-COVID gut-lung axis derangement was one of the reasons for persistent GPC. And this GPC and persistent cavities in the lung made him more vulnerable to hospital-acquired infection due to prolonged ICU stay. So these things made us understand the root cause of secondary deterioration was sepsis. And weaning of the first ECMO was purely based on clinical recovery and was not a decision failure, as the patient continued to be stable for 15 days post ECMO removal. And double ECMO in the same patient and in the same hospital duration is possible, but we should be convinced about the reversible cause and treatability of clinical deterioration, especially in view of sepsis, and a timely decision to reinitiate the ECMO has to be taken. And counseling the family about reinitiation of ECMO is of paramount importance, as it incurs huge cost, and this family bystanders were really cooperative also. Next, appropriate broad spectrum antibiotic escalation along with filters is the basis treatment and plays a vital role in the recovery. Usually antibiotics, we have antibiotic stewardship committee, so and ID, so according to that, we use the antibiotics very meticulously. And it's a team effort where the floor intensivists have to have a quick decision making, counseling and coordinating the initiation of ECMO. Weaning of ECMO in the second initiation is very crucial and has to be decided upon the clinical recovery, serial CT and lab parameters. Thank you.